All right, if I could have everybody go ahead and take a seat. We're on a pretty tight schedule, so I want to go ahead and get us going. I want to thank everybody for coming out today. My name is Chad Hodges, and I'm the VP of Business Development and Enterprise Networking Solutions. And today we have an exciting presentation from our friends at Healthcare Services. They're going to be talking about their strategic plan for enterprise architecture. And it's kind of exciting because you don't see this oftentimes in this space, the transparency on something like this. So it's kind of an exciting time to be able to share and see what the future of not just healthcare, but possibly what the state could be doing with regards to this space. So I want to first take the opportunity to introduce Greg Franklin. He's going to come up and say a few words about what they're doing in the healthcare space with regards to these topics, and then we'll go ahead and introduce Alex Castro, who's going to introduce the panel as well. All right, thank you very much.
Thank you. It's not often a state employee gets applause before they speak. It doesn't happen, but I appreciate it. Thank you. First of all, I want to thank TechWire for hosting this event and certainly recognizing the importance of enterprise architecture and where the technology agency is going with it, and hopefully we're showing enough leadership to move other departments in that direction. Let me say first, when Secretary Ramos first came into our office and certainly came as our new secretary, one of the things he focused on in talking to all staff was efficiency, economies of scale, shareability, and being able to take the limited resources we have in IT and state government and leverage those toward better solutions. Over the last year, with the hire of Subaru Mukaraju as our Chief Enterprise Architect, we've been working on a California-specific statewide framework for enterprise architecture, much like MITA and FIA and TOGAF. During the course of that development, we've reached out to various departments and stakeholders, and we've shared with them our thinking and also shared with them our drafts. I'm happy to say that Cruz in Department of Healthcare Services, and many of you who know me know I spent 18 years in Department of Health Services and recently spent another 18 months there working on a special project. But Cruz in the Department of Healthcare Services took the bull by the horn and led that department along with the various departments that he's inherited through consolidation to get to a place where he's leveraging the thinking that's going into our framework to build upon what he needs to do to ensure that that department remains relevant in terms of its IT commitment to services. I will say that there are many more efforts like this underway in the various other departments, and hopefully we'll see their work come to fruition soon. And at the same time, we will soon see the CTA version of a FIA, MITA, or TOGAF being released hopefully here in the near future, like the next couple of weeks. So with that, I want to welcome you on behalf of the California Technology Agency. Thank you, as I look out in the audience, thank you for all your support. I see many of you I've met with over my 2 years with the Technology Agency, and hopefully you'll continue that support. Thank you.
All right, I'd like to go ahead and take the opportunity now to introduce our main sponsor for today's event, Alex Castro from MCorp, and he's going to go ahead and introduce our panel. Thank you.
Wow, no love at all? Yeah, that's what you get. So in trying to prepare for today, I tried to cull up a joke or something. I went on the internet and looked up ESB, and any joke that came up was about Empire Strikes Back. And then I tried to get jokes about enterprise service buses, and the only thing that came back was about modes of transportation around Microsoft's campus in Redmond. So I thought I'd kind of leave it alone at that point and go in. So I'd like to welcome everybody this morning, and it's a very special event, and we're at MCorp very pleased to be a sponsor to make this event possible. With nearly a $1 billion portfolio, Department of Healthcare Services IT organization oversees the interfaces with the major projects being designed to deliver the next generation of healthcare to Californians. Accomplishing this will be will require the adoption of next-generation technologies, methodologies, and the development of best practices for DHS's unique challenge and culture. As many of you heard from Greg, this enterprise architecture plan is the first and many expected to come out, and the state advances its agenda to coordinate across departments like it has never done before. But today, we're going to be looking for some answers from the department. And for example, what will it look like when they advance the Medicaid Information Technology Architecture, MITA, maturity model? To support this, the state's private sector partners are working to gain a better understanding what is the new terrain and what it's going to look like. And how does the department's newly released strategic plan come into play? Who are the stakeholders? What's included in the department's business architecture, information architecture, and technical architecture? With this plan being released today publicly for the first time, there are just some questions that Cruz, Ben Word, and Dr. Linette Scott will address. This team has broken down this technical information into a common language that everyone can easily understand. During the presentation, the panel is encouraging an interactive session, I believe, right? Questions, where those questions can help provide a broader understanding of this highly complex agenda. It's going to be pretty heavy in tech, and I think they've done a great job of bringing that down into a very conversational state. So without any further delay, I'd like to introduce Cruz, CIO and Deputy Director of Healthcare Services.
Well, good morning, everyone. Thanks for coming in. I'll lower this a little bit. Is that better? Great. You know, for those of us that are vertically challenged, these things have to be a little lower. So, all right. So what we're going to talk about today is really our strategic framework at the Department of Healthcare Services. I don't know if many of you are aware, we published our IT strategic plan about 5 or 6 months ago, and we have that out, obviously, published. But one of the things we're getting ready to publish now is our departmental plan. And so really what this represents is a roadmap and an interesting dichotomy of putting everything together. And one of the things you'll see in front here, actually on the front table here, is our IT strategic toolkit. And we wanted to put this together because we feel like it's very important to have a roadmap and a framework for the things we're doing at the Department of Healthcare Services. We want a 5-year strategy. Because a lot of times, you know, you come in and execute and you get things done, and you usually, you know, you do it on an ad hoc basis. So we want something really that's sustainable and repeatable, and something that's usable not only at healthcare services, not only with an agency perspective, but also something that can transcend on a statewide basis as well. So that's really what we wanted to do in putting this architecture framework together, putting this strategic strategy together, and really how it aligns. And as Greg Franklin talked about from the technology agency, we want to make sure it aligns with the technology agency architecture as well. So REA Ben Word, who you'll hear from later, has been working with Sabaro on ensuring that there's alignment there, and it's consistent and complementary with that approach. Because a one-size-fits-all is really important to the state in terms of how we do business. So really, what we have in front of us today is really the as-is model and what we're looking at. Basically, our Medicaid information technology architecture is required. The Center for Medicare and Medicaid Services requires that we have a plan in place. And really, that is a funding structure in terms of how we do business today. And right now, in our Medicaid area, under eligibility and enrollment, we get 90-10 money. And so we're obviously looking at doing something, modernizing our Medi-Cal eligibility data system. We're participating and involved in the integration of the CalHERS project right now, which is the state benefit exchange, and also with the Medicaid Management Information System project. So we wanted to have a fundamental strategy and roadmap that we can follow and execute from. So really, what does that mean? One of the areas that we've been looking at throughout this department before I became CIO is our technology architecture maturity. And we found that our maturity level was really a 1 and 2, which is really very minimum, and that we needed to improve on our maturity level. We have a lot of disparate processes. 141 different business processes are implemented across our Medi-Cal area. So we needed to find out how we could integrate those. And obviously, from a system perspective, from an information perspective, from a technology perspective, we wanted to start connecting the dots. And you're going to hear more about that as we do a deeper dive in today's discussion. Again, we have MITA defines 80 business services across the Medicaid business areas. So those are the things that we're looking at and gaining maturity. And really what this is about is education. And what we found with the architecture framework, it's not a technology solution, it's a business solution. And how we've been driving this, and you'll hear more about this from Dr. Scott as we move forward, is through really data governance in our organization. Once I worked with our enterprise architect on developing this framework, I sat down with the director and chief deputy of our department and really talked about this as being a business strategy. Because one of my concerns has been with architecture is it's very complex, it's very hard to understand from a business perspective. So we broke this thing down into bricks and mortar, and I think Ben will do a really good job of dissecting that here in a few minutes. But that's really the importance is we're driving this across our business, and Dr. Linette Scott, who's our Chief Medical Information Officer, and our Chief Deputy Director, Karen Johnson, are helping Ben drive this. And so we're doing a series of meetings, what I call fireside chats, with each one of our business deputy directors at my peer level to really drive the importance of the plan, how we're going to lay out this framework. This is going to be part of our budget change concept and our budget change proposal as we move forward. So as we acquire state resources, as we go after IT dollars in the federal area, that all of these diamonds need to be able to connect, and we need to connect the dots across this process. So the business people are now understanding that is an entrance criteria into the things that we're doing in this organization today, and that we're going to continue to do that. So it's part of our feasibility study process is how well we look at things now. It's part of looking things from a holistic enterprise approach. So that's what we're laying out here in terms of those technologies. With healthcare services, unlike many large healthcare organizations, we are the largest state Medicaid organization in the country, next to CMS. So $63 billion come out of this department each year in terms of providing provision of services to low-income Californians and also for providers in terms of making sure they get paid on time, on budget, and on schedule. So that's the importance of the multitude of things that we have here. We have multiple technology solutions. We have multiple applications, software, and platforms. And one of my big bugaboos in developing the CA framework when I first met Ben was, you know what, we need to significantly reduce our enterprise debt in this department, both from a hardware perspective and a software perspective. And an ensuing slide and what I'm going to show you really points to what I'm trying to address. And this is really our as-is technology stock sample, and I apologize, this is probably hard to see on the screen, but I think we're going to hand out the information later so you have that within our toolkit or other information on TechWire. But this really speaks to the enterprise debt. And as you can see, many of you vendors that are represented here in the audience today are also up on this board. And so you can see that we have multiple software in certain areas like business intelligence, content management, software configuration management, operations support, software development framework and integrated development environments, programming languages, database management systems, operating systems, and web application servers. This is too much. And as Greg spoke to earlier on, we at the department have inherited some other departments. The Department of Mental Health has come over to the Department of Healthcare Services and their 50-plus applications. Drug Medi-Cal from the Alcohol Drug Program has come over to the Department of Healthcare Services. The rest of the Alcohol Drug Program will be over at the Department of Healthcare Services as of July 1. We've inherited a couple of small advisory commissions, and then also Mr. Mid with the Healthy Families Program has been incorporated into our Medi-Cal system. So you can see that we're growing as an organization, but we're also increasing our enterprise debt. And kind of like the national debt, you know, some say there's an argument about whether that's good or not. You know, we think that there's some certain opportunities here to reduce our software maintenance agreements. We pay, I think, between $4 million and $7 million a year growing just in maintenance fees for software alone and some hardware. That's too much. And so my job through the strategy that we're going to lay out is to reduce that debt and look at licenses where we have, and systems and software where we have like functionality to be able to distribute that. So over the coming months and years, I'm going to be working with the vendor community to really reduce our enterprise debt in these particular areas. And again, I think that these are opportunities not only at healthcare and within our Health and Human Services Agency, but also the state that we can transition and transcend some of these areas and look at maybe some enterprise licensing and shared services as we move forward. You'll also hear, too, about interoperability in this framework as well. We're going to talk a lot about interoperability within the agency and what we're doing. I've been working with our Agency Information Officer, Shell Kelp, on looking at interoperability opportunities, if you will, across Health and Human Services and how we can continue to consolidate from a data perspective. So moving forward, our 2B technology stack example, this just gives you some ideas about security and privacy, where we're at and where we would like to go within this particular area. You know, looking at policies, looking at management, and looking at the technical perspectives from the SAP perspective. Also, coordination of event notifications and public subsidies and subscribing. Access channels, and we're looking at adaptability and extensibility into our systems. And you can see within our web administrative portal, you know, the kind of areas that we're looking at right now. And I know Dr. Scott's going to do a deeper dive in this, is, you know, business process management. We have the health insurance exchange, the health information exchange. We have metadata models that we need to look at in our organization, the metadata dictionary, interoperability manager, data stream, message block, data and information resource management, and communication protocols. So what we're really talking about is data linkages here and how we need to link this information up across our organization to be a more effective provider in terms of distributing data. And I think that that's really important as we move forward. So you can see it's kind of wrapping around where our security technology is coming from in those particular areas, where we have access technology, where we see our BPM services and information technology, and how that moves forward. So this is an example of an as-is redundant process. We wanted to provide something. Well, give us an example, some of the things, Chris, in your organization that you're looking at. And the example here that we thought about is provider enrollment. Well, you can see with provider enrollment, and as we move providers into our organization, you can see the different areas and buckets within our organization that provider enrollment goes into. And obviously, these are the areas that we're talking about in terms of data integration and interoperability opportunities. It's a lot, and there's a lot of processes going on here. And you can see with Medi-Cal, authorized with TCM, through our drug program, our dental program, Child Health and Disability Prevention Program, IHSS, which flows through the Department of Social Services, our California Children's and Medical Services Program, managed care, and also mental health. So you can see where we're connecting the dots here, where there's multiple owners and multiple data flowing into a system of provider enrollment. So this is an area we've addressed for MITA compliance that we think we can become more mature at as we move forward from that perspective. Also, too, in terms of this, looking at provider management, looking at provider enrollment, and looking at the Medicaid information technology process and how we enroll providers across these organizations. So we're giving an example of how we're using the EA framework that we've constructed to break down some of these particular areas. And really, I'm going to let Ben really drive that and break that down into the bricks and mortar. So really, before I really introduce Ben Ward, I wanted to talk to him a little bit about the organization. When I became CIO in January of 2011, what I wanted to do was introduce an enterprise EA competency into the department. So I was fortunate enough to already have Ben there. So we rebranded Ben to say, you know what, give me an EA framework and a roadmap that makes sense. Because we have a number of legacy transformations we're doing in our department over the next, 10 years. And we're changing the way we're doing business based on the terms and conditions of the Affordable Care Act. So give me a roadmap and give me a plan and a strategy that I can use to drive this organization and ensure that we're successful. Because this is really a public-private partnership. We need vendors to be successful just as much as we need to do state staff. And so we wanted to lay out a strategy so when you bid on RFPs, you come into our organization, you understand what our core competencies are, what the institutional knowledge is, and how we look at knowledge transfer within our respective organization. So really, this is the approach. So anyway, I'm going to ask Ben to come up and talk about really a deeper dive into the EA strategy so you can understand it a little better, and then Dr. Scott will come up and talk about the data outcomes from those particular perspectives. So without further ado, I'm going to ask Ben Ward to come up. Ben?
Well, hi, everybody. As Chris mentioned, my name is Ben Ward, and I'm the manager of the Department of Healthcare Services Enterprise Architecture Office. This PowerPoint presentation will provide an orientation to DHCS strategic vision drawing. So there are drawings we have in the audience here as well. So as Chris mentioned, Karen Johnson, our Chief Deputy Director, Dr. Linette Scott, who you hear from next, and myself have been delivering this presentation to our division chiefs, managers, and supervisors over the past 4 to 6 weeks. They were also provided with a poster of the vision as well as a toolkit. And Chris mentioned the toolkit, so please take a look at the toolkits afterwards. They're up front here as an examples. To communicate this throughout the branches. There we go. So my agenda today is pretty straightforward. It's pretty simple. Talk a little bit about the background of the EA program itself. Chris did a real good job, kind of overviewing our as-is processes. I want to talk about the vision, where we're heading, and the components of the actual strategic vision drawing. I'm going to break that down a little bit. So background, DHCS has received multiple requests to explain the vision of the 2B environment. What will the department look like when we advance in our MITA maturity? What will the department look like when we focus on enterprise architecture initiatives? So DHCS has drafted a 2B vision drawing with leadership from the Enterprise Architecture Office, and I had a whole lot of help too, let me tell you. So what we started with here is it is necessary for any organization to have a vision that can be clearly communicated and understood by the entire department. So a strategic vision drawing was produced to provide a pictorial representation of what the department might look like as a mature, MIDA-aligned enterprise. So the drawing, or components of it, will be submitted to the Centers for Medicare and Medicaid Services, which is CMS, as part of advanced planning document submittals to demonstrate the DHCS future state. CMS provides financial funding participation for approved projects that further MIDA maturity in the department. This future won't happen overnight, as this much change will require phased projects that continually move us forward towards this to-be state. As we work on developing the roadmap to achieve this vision, everyone at DHCS, this is the message we're getting out to them, everyone at DHCS will have a role and they will have a voice on our journey. So a little bit of background too on my perspective of DHCS. Share a little bit that I've experienced the 5 years since I've been there. It's really interesting. I'm not sure how to explain it, but there's this overall sense that I get when I'm there, working with the people there, that it's not just a job, that it's more of a privilege to serve the citizens of our state. So it's really exciting to come to work. But then there's also this colossal challenges, if you would, that the department embraces and continually produces positive outcomes with. So this is achieved by the incredible, dedicated, and hardworking staff that I have seen. But then it's fostered by the leadership throughout the department that provides clear vision and opportunities to succeed. So I guess the reason I'm bringing this up is that even though the department is doing great things, there's always room for improvements. So we believe that the Enterprise Architecture Program will participate in assisting the department to meet our commitments as we experience transformation. The Enterprise Architecture Program at DHCS is the discipline used to increase the effectiveness, efficiency, agility, and durability of the enterprise by supporting the management of cost, risk, flexibility, and quality of change, using structured models, performing EA governance, and recommending enterprise investment opportunities. So you see we highlight enterprise here to help us focus on optimizing efficiency, effectiveness, agility, and durability across DHCS as a whole. We also highlight change here, since enterprise architecture will provide guidance and governance for all types of strategic and tactical changes within DHCS. So here's a strategic vision drawing, if you didn't see it on the way in here. I've had reference to it that it looks like the cockpit of a B-52 plane, but it's actually a very condensed replication of what the department could look like at a MIDA maturity level 3 through 5. If we were to do the as-is of the department, it would be very complicated, very hard to read in one diagram. So we had a lot of brain power, a lot of help. We had some great people giving us ideas on this, ran it up through the chief deputy director area. The reason we ran it through the deputies and the division chiefs was to get their suggestions on how to improve or modify the drawing to where it's meaningful to them, because it has to be driven from the business perspective. So Chris asked the enterprise architecture to come up with a pictorial view of where the department wants to head. So to ensure that the programs, information, and technology decisions that are made align with this vision. So this vision drawing depicts a future architecture, a target state, if you will, represented at MIDA maturity levels 3 through 5. It's framed by the department's strategic plan at the top and our quality strategy at the bottom. The diagram highlights cross-cutting interactions and services while putting focus on the 3 domains of MIDA. So for the remainder of the presentation, I will explain the details contained within the drawing. I will start at the top with our strategic commitments and then move to the bottom and talk about the quality strategy at the base, which is our anchor. Then walk through the middle of the drawing, working myself down. DHCS transforming and innovating to achieve its commitments. So the top of the drawing starts with the focus of the DHCS strategic plan. Our strategic plan is focused on commitments, which we have associated strategies as well. And the strategic plan, I think, was just released. Has that been publicized yet? I don't know if it's been out in public yet, but so we're aligning this up with the release of the department's strategic plan. And we also align this up with the IT strategic plan, which Chris released earlier this year. So a little bit about the bullets there. To the public. So California citizens look to DHCS to provide affordable and available management of Medi-Cal and the other vital healthcare programs which we administer or participate in. To the people we serve, members should be given timely services through modern methods to support their healthcare experience. And to our employees, setting and maturing this DHCS strategic vision enables clear communication, common direction, and easily understood success criteria to enable all of us to do our very best. So now at the very bottom of the drawing, this is our anchor. This is the three-link goals in the DHCS quality strategy that form the base of our vision. This is consistent with the Institute of Healthcare Improvement's triple aim and the three aims of the National Quality Strategy. So DHCS's quality strategy is anchored by three link goals: improving the health of Californians, enhancing healthcare programs, and reducing healthcare costs. Dr. Linette Scott will go a little bit more into detail in her presentation on the triple aim quality strategy. So now getting back up kind of in the middle of the drawing, if you would. It's at the very top, but in the middle section. We start with highlighting our stakeholders. I'm not going to read each one of these, but what we wanted to do is make sure this list will serve as a constant reminder to all of us that each stakeholder plays a pivotal role in achieving our commitments, either as a consumer of our services or a partner to assist in our efforts. Then we get into MIDA. So MIDA drives the building blocks. You'll see we have three architecture domains there. As Chris stated, MIDA stands for Medicaid Information Technology Architecture, where the emphasis is on the Medicaid business programs. So the goal of MIDA is to change the way the states design, build, or modify their Medicaid systems, the information that supports the business processes, and the manner in which states perform IT investment planning. So based on MIDA, DHCS Enterprise Architecture aligns with all three of the building block domains: business architecture, information architecture, and technical architecture. So starting with the business architecture, it's a blueprint of the enterprise that provides a common understanding of the organization that includes the services provided by the organization. So the second banner from the top highlights the DHCS vision: to preserve and improve the physical and mental health of all Californians. The next section is the 2B business areas. That's the biggest section in there. There's 10 blue boxes in there that represent the MIDA business areas. The white boxes or circles underneath that represent MIDA business categories. And poster would have gotten real busy if I would have put all 80 business processes on, but that's part of the intent as well. The light banner highlights the DHCS mission: to provide low-income Californians with access to affordable, high-quality health care, including medical, mental health, substance use disorder services, and long-term care. So the bottom three boxes at the bottom, we came up, we wanted to have some outcomes. So what would be some intended outcomes of what we'd like to see in the business architecture? So we have to have effective, efficient, and sustainable healthcare delivery systems, to improve and maintain health and well-being, and to foster communication, collaboration, teamwork, and effective decision-making. So next is the information architecture, which provides a blueprint of the information strategy that includes enterprise data models, policies, rules, and standards that govern how data is modeled, collected, stored, arranged, and exchanged, and reported on as an enterprise asset. So this is looking more at an enterprise asset than siloed data storage for DHCS. Once again, we have the bottom three boxes, outcomes we would like to achieve: efficient and secure high information exchanges, improved quality of health data for Californians, compliance and security risk reduction. The technology architecture provides the blueprint for the technology strategy, which includes processes, tools, technologies, standards, and best practices required to implement, manage, and monitor the business, technical, and information services capabilities. I learned this word a lot from Sabaro. He used capabilities quite a bit, so we're focusing on capabilities, which will align with the department's IT strategic plan. The bottom three boxes are outcomes we'd like to see achieved in the partial list of the technical architecture: building shared, reusable technical capabilities, dynamic resource allocation, and also compliance and security risk reduction, common theme. So now I'm going to work my way towards more towards the bottom of the poster. There's some banners down there that we have that represent an end-to-end solution that we're looking at the components of what we're doing here across the enterprise. So first is our core values of our dynamic workforce. We start with integrity. We shall conduct ourselves in a transparent and honest manner. Service. We are approachable and offer assistance as needed. Accountability. We are open and prudent fiscal stewards of public resources. Innovation. We provide a safe environment for all employees to create and innovate. So next is the security and privacy banner. With the focus to align to the MITA security and policy framework. It is built on state and federal security and privacy requirements, guidance, and best practices, and is integrated, once again, within the overall business information and technology architectures. So our intent is to foster a culture that automatically integrates privacy and security as part of our daily decision-making process instead of an afterthought. Next banner is maintenance and operations. We have centralized deployment, configuration, and versioning. So this is to deploy, configure, and version a multitude of services. So we're starting to talk a lot more about services in our department, trying to get that into our vocabulary, in a consistent manner throughout the enterprise. We have centralized management and monitoring, rapid cycle quality improvement, and analytics and reporting. DHCS produces a wide range of analysis and reports. The 2B architecture will provide analytics and reporting capabilities as enterprise services. Followed by portfolio management, which includes the following components: project management, program management, agile methodology, which is an alternative to waterfall or traditional sequential development that we mostly do here in the state, change management, and MITA alignment. So this demonstrates, the MITA alignment portion demonstrates how the California's Medi-Cal enterprise is aligned to the CMS MITA framework. This also involves showing how project work progresses the DHCS Medi-Cal enterprise towards increasing MITA maturity levels with respect to business, technical, and information architecture and processes. And finally, governance. Enterprise governance defines projects, processes, policies, matrices, and best practices to develop organizational competency for enterprise strategy developed for DHCS in a holistic manner. Then we have SOA governance, service-oriented architecture. This aligns with a consistent theme throughout the vision I've been talking about to create enterprise shared services. Information governance. That is currently performed within the Health Information Management Committee, led by Dr. Linette Scott. IT governance is performed within our ITSD division with leadership from Cruz and Barney Gomez. So then down at the bottom, we have an arrow at the bottom of the poster providing some highlights of change currently happening within the department. And this is stuff that's happening to us now and projected as we go forward. So it's a vision, some of it. So change has many faces and drivers in the transformation and innovation of DHCS. This is not an exhaustive list. So on the poster, we highlight Centers for Medicare and Medicaid Services, CMS. They give us the federal regulation, enhanced funding opportunities. Then we have delivery transformation. So we'll be expanding Medi-Cal. It's part of the Affordable Care Act and what we're going to be doing. So we have that going on. Payment reform and another initiative, coordinated care initiative. Then we have a provider section. We have provider enrollment process improvement project. This is in alignment with what Chris was showing us with the overlap of business, the provider enrollment business process. So we have a project that's coming up called PAVE that should help us to align more up with the MITA framework. And then we have Claims Processing Improvement Project, which is CAMUS. A lot of you are familiar with that one as well. Our members box, that's really going to be with the Health Benefits Exchange, the Covered California Healthcare Options. Then we have California Health and Human Services Agency. Chris mentioned that about the interoperability project opportunities. So we're really looking at partnering with our sister departments at the agency level to see how we can better do this, interoperability at an agency, not only just at our department levels as well. So then we have their business box, enhanced program integrity, very important in our department right now, consolidated processes, and shared services. Our information box, we have health information exchanges, electronic health records, paid claims encounter system, and the data warehouse, which we hope to modernize here shortly as well. Technology, agile IT systems, aligned with business strategies, common IT services. Just some of the highlights of change that's going on in the department right now. So that's where we expect the vision drawing to also be updated and modified as we go forward, as some of these initiatives gets finished and others come up as well to keep us in line. So to conclude, what we shared today is just the beginning of what we're doing in the Department of Department of Healthcare Services in the area of enterprise architecture. So some of our next steps include using the MIDAS state self-assessment that the Office of HIPAA Compliance is conducting with our business programs to develop a roadmap with priorities that will continue our transformation to ensure we achieve our stated commitments. So with that, I would like to introduce Dr. Linette Scott. She is the department's Chief Medical Information Officer.
Thank you, and it's a pleasure to be here. And I might take a moment to explain a little bit about my role. The Chief Medical Information Officer is a new role in the Department of Healthcare Services, and I've been in it for just about a year. So I think it's starting to get a little bit more shape to it. But this is a role that is often seen in the clinical side of things, in healthcare delivery systems, hospitals, et cetera, and it's really been emerging as part of this transformation of technology in healthcare. And so the role is, I'm a physician, I'm board certified in general preventive medicine and public health, and I serve, though, in this role that crosses over between the business needs and the technology needs. I am thrilled to have experts like Chris and Ben that are dealing with the technology components. What platform do we use? How does it work together? Make the systems go? But being able to provide that piece around, well, what we want it to do is this. What is it that we need to solve? How does that translate? And helping some of my program and business side colleagues make that translation. So over the last 7 or 8 years or so that I've been with state government, I've had a chance, and a huge thank you to Greg Franklin, who helped me get into state service, in learning some of the IT side of things. So I live in this informatics role, and on our diagram, I'm in the green box, is kind of where I sit. And so part of the role that I'm doing here now, too, and sort of tying this up, is what does this mean, right? So we have our diagram. We've outlined the components. It puts these pieces together. We're framed with our strategic plan and our quality plan. So what is it going to help us do? And this is where I really feel a sense of urgency. So one of the roles that I had an opportunity to play before I came to the department is that I served as the interim deputy secretary for health information technology at the Health and Human Service Agency. And as part of doing that, I had responsibility for our high-tech programs and coordinating those in the state, and that's the Health Information Technology for Economic and Clinical Health Act. Yes, I've practiced that a few times. And that was passed in 2009. So in 2009, 4 years ago, as part of the American Recovery and Reinvestment Act, the HITECH Act was passed. And what this did is it put a carrot out there, and it said, we've been trying to change and get technology into healthcare for years. We've been working on this. It's not quite happening. It clearly needs a push. Here's the push. We're going to put a bit of money out there. In the scheme of things, not a lot. State of California, we expected to get about $4 billion overall. I think somebody mentioned our DHCS budget is around $63 billion. So $4 billion over a bunch of years to try to help nudge this along. And it was something of an experiment, but you know, it's working. It's got people's attention, and it's happening, and it's transforming. So on the clinical side, we've had a role around really working closely with our providers, our clinical systems, hospital systems, healthcare delivery, to get technology into place and move from a paper-based environment to an EHR-based environment. Recent headlines have been coming out of the Office of the National Coordinator for Health IT saying we're hitting 50% adoption. part of this is about hitting that tipping point. I was talking to somebody earlier. We had conversations around health information exchange a couple years ago, and it was hard because we weren't ready. There was not enough adoption of electronic health records to have electronic data to exchange. We're there now. It's very much happening. So there's been this transformation. Many of the high-tech programs will actually be ending this fall and at the beginning of 2014. So the regional extension centers, the HIE cooperative agreement, the Beacon grant, those will actually all be ending. The Medicare EHR incentive program will be going for a little bit longer. It is a incentive program until somewhere around the 2015-2016 area. Then it will become a penalty program. But the Medicaid EHR incentive program, which we're responsible for and reports to me, is an incentive program only, and it goes through 2021. So we are helping providers both in terms of incentive payments for adopting electronic health records, but we're also looking at what other kinds of technical support we can provide to them as they continue the adoption of electronic health records. And as with any other automation project, it's not just about the technology, it's about the business process change. So many of these programs have been targeting the efforts around sitting down with a provider and saying, how do you work now? How can you work if you had electronic technology? And how do we help you get there? And that, I think, has been a huge part of what's made this transformation successful. And even though the incentive payments are only going to Medi-Cal and Medicare providers that have enough of their patient population in our payment systems, the organizations they work with are adopting for the whole organization. So it's touching much more than just those individual providers. The other part, though, that really is an alignment area, and so this is an area we really want to focus on, and why the strategic vision drawing is at just the right time, is tying again to our might and maturity. When we look at Medicaid information technology architecture, what does it mean? It ranks from a level 1 to a level 5, okay? We're at 1s and 2s right now. We would like to hit nirvana at 5, probably, not in the next decade, but you never know. But just as an example of how this ties together, one of the business processes is managed treatment plans and outcomes. And so it says at a level 1, that would be process consists primarily of manual activity to accomplish the task. It's kind of sort of where we're at. We may have some technology that supports it, but it's still fairly manual. Level 3, the state Medicaid agency automates the process to the full extent possible, which means in accordance with applicable law and practice type stuff, within the state health information exchange. So to hit a level 3, we need to exchange information from the state Medicaid agency to the EHRs, to the health information exchange activities in the state to help support provider care, treatment plans, and outcomes so that we can have the best outcomes for the members we are taking care of. At level 5, we automate our process nationally to the extent possible, and we hook up to the nationwide health information network. You can tell this got written before we went through 2 or 3 changes of what the nationwide health information network looks like. Can't remember exactly the name we're on right now, but the idea is to connect nationally. So California is so big. We have on the order of 24 health information exchange organization type activities going on at different levels of maturity. About half of them are community-based and about half are enterprise-based. So enterprise being like the Kaiser system or the Sutter system or the UC system, University of California. So we have 24, so we're kind of like half the country, So we have a lot of work right now that's working on helping those folks connect. What does it take to connect? How do you have the trust, the security, the privacy, the data sharing, all those pieces that put it together? So a key role for us is, both because of MIDA, our framework, and this urgency, is getting us connected to that as well. Obviously, the mainframe legacy systems, those move slowly, but what are those things we can do on top of it to get it to connect? And that's some of the things we're going to be exploring very much, and that's why I'm so thrilled to be working with Chris and Ben. If you haven't been here, this is the Health IT dashboard. The link's at the bottom. It's dashboard.healthit.gov/meaningful-use/. This is hosted by the Office of the National Coordinator for Health IT and shows adoption. So if you want to see how many folks have been paid, what are the number of EHRs that have been adopted, how much e-prescribing is happening, how much laboratory exchange, they update this dashboard on a regular basis. So this is just a snapshot. But part of what this shows is that currently in California, over 22,000 providers, eligible professionals and hospitals, have received incentive payments. So that's over 22,000. And over, I think it's about $1.2 billion of federal dollars have gone to providers, hospitals, critical access hospitals through the Medicare, Medicare Advantage, and Medicaid programs. So that's what's really pushing this forward, and it is very much happening. So this is helping us to drive quality. So in order for a provider to get a payment, a meaningful or an incentive payment, they have to do three things. They have to use a certified EHR, which means that EHR has been certified by another body. It can do things, and it follows certain standards. It follows HL7 2.5.1. It uses vocabularies like CVX, ICD-9, SNOMED, LOINC. And it will transport data in specific ways, okay? So certified EHR to start with. So that tells us what kinds of standards do we need? We need standards that can interface with those. So ONC, EHR certification standards, that's what we need to do. 2, they have to meet the meaningful use objectives. And there's about 24 of those, about 12 or so that are core required, and then some they get to choose from. And those are things like use computerized physician order entry, do medication reconciliation, take vital signs including body mass index, height and weight, check the smoking status, know the problem status, know what laboratories have been ordered, report to public health as you're legally required to do. A wide variety of things, all about patient care, and make sure it's done privately, with privacy and security standards, and make sure you're engaging the patient, because as part of stage 2 in particular, we're really seeing the patient portal aspect. Make sure you get the health information that applies to the patient, and remember, everybody in this room is a patient at some point in time, so that you have the information about yourself. That's a requirement. So that's the second part, meaningful use objectives. And the third part is clinical quality measures. And this says we want to know how is your practice performing, and how are you performing compared to your peers. And you need to report on a selection of clinical quality measures for your entire patient population, not just the Medi-Cal members. So out of that, we will be seeing that kind of data about how practices are performing. And those quality measures, again, align with the national quality strategy and the domains there. All this ties together because we have one of our very important initiatives mentioned earlier, the Coordinated Care Initiative, CalMedi Connect. We're working really hard to get ready to launch that coming up in the near future. It's all about care coordination. You can't do care coordination without technology. There's about 100 quality measures that are going to be part of this that people are going to have to report. Again, we just can't do this without the technology support. So critical to that. Also, the state's very active. We did receive a State Innovation Model Initiative planning grant, so that is well underway. And these are screenshots from both of those programs. If you want to know more about the State Innovation Model, see our Health and Human Service Agency website. Again, looking at how we transform the way we pay for care, and not by each transaction that occurred. It's about the outcomes. For our state innovation model work, we're jump-starting that off of work that was done last year that was spearheaded by our secretary, Diana Dooley, in partnership with Dr. Don Berwick, who was a previous administrator of the Centers for Medicare and Medicaid Services, Medicare and Medicaid Services, excuse me. And so the Let's Get Healthy California Task Force was convened last June, and by December produced this report and the framework around how to approach helping to make California the healthiest state in the nation. That was the charge from the secretary. So we identified this framework. It's focused around the triple aim: improve the population health, improve the quality of care, and lower the cost. And it's built across this framework, looking across the lifespan, early beginnings, living well, and end of life. And folks have been impressed that the task force and the secretary was willing to take on that end of life. But it's critically important to us as individuals and a society. Pathways to Health, that looks at how we are redesigning the health system. Many of our programs at Department of Healthcare Services are involved in that. Creating healthy communities, because most of what happens in health is not in the doctor's office. And yes, I'm a doctor, so I'll say that. It's about the community you live in. It's about having food to eat, a safe place to walk, education for your kids and your adults. and then lowering cost of care. So this is the framework that we're building around, and we're aligning with as a department as well. And so it really is this focus on outcomes. So why does this technology platform matter, the enterprise architecture matter, getting this working right so that data is consistent and comparable? My favorite example is race ethnicity. There is a national standard. It's called out in the EHR incentive program. EHRs are to collect race and ethnicity in accordance with the Office of the Management and Budget OMB standard. Yet we collect it many different ways, which means you can't take that data field and compare it and look for disparities and inequities. So I just wanted to close with this picture, and coming from a public health background, the top maps here are something I think we saw in our sleep, but I've realized that many people haven't seen these maps. But these are maps that the data is generated based on a telephone survey, the Behavioral Risk Factor Surveillance Survey, and it looks at obesity in the country, overweight and obesity. And based on that, it starts in 1990, where the country looks kind of blue, and then 1999, and then 2009. So these are 10-year snapshots of how we have literally grown as a country, and not by population, although we've done that too. And you can see the geographic variation. And so in 2009, Colorado was the one state that hadn't turned red yet out in the scale, going from white, light blue, blue, dark blue, beige, orange, red. So there's a crisis here, and this is a crisis that we're very much focused on. It is an obesity epidemic by the definition of the word epidemic. This is something we have to tackle. It's driving our healthcare cost, it's driving our community cost, it's driving your health and well-being, how you feel, how you operate, what you're able to do. It's affecting our children. We've heard the statement, we may have children now that are going to have a lower life expectancy than their parents because of the obesity situation. This is something we have to tackle. In the 1900s, the big thing was infectious disease. In the 2000s, it's chronic disease. And it's chronic disease, and one of the big drivers there, tobacco we're doing pretty well on getting that rate down. But obesity is tough. It's tough because it's multifactorial. It's about how we eat. It's about how we exercise. It's about how we move. It's about how we work, the work environment. So lots of focus, as the Let's Get Healthy California Task Force talked, lots of focus on worksite wellness. How do we literally configure our work environment so that it can help us be healthier, as well as a variety of other things. So this is one of the areas we're focused on. And then another area that we're really strongly focused on at Department of Healthcare Services, again, is around patient safety and how we make sure that we do follow our motto of first do no harm in the medical profession and make sure that the care is safe for those that receive it. We know that there are far too many issues in our healthcare delivery system, and so we really are working to tackle that as well. Can't do it without data and can't do it without technology. So we're really pleased to have the chance to share this with you, to partner with you, and to be working towards these goals as we move forward. It's all about the interoperability, taking care of those members, our critical populations. Some of you have heard about some of the work we're doing around the interoperability grant that was mentioned earlier. For that, we're focusing on psychotropic medications in foster children. Small population, but a critical population, and a way to give it focus, because this thing is so huge, it feels like a big elephant, but how do you eat an elephant? One bite at a time, right? So we're here to do that, and we're pleased to be here. So we really look forward to taking questions and receiving feedback, and I figure the first question is going to be, okay, where are the materials going to be? So we will be working on posting these materials on our website, and as you've seen, this has been recorded, and we will be making that available as well. So as that comes out, as you all registered, you'll get the email saying where to go find it. We don't actually have it up today, but we will be doing that in the near future. So you don't have to ask that question, but thank you.
Thank you very much. I want to reiterate our thanks to everybody for the participation today, not the least of which to our sponsors and to our esteemed panel, so thank you very much. Without further ado, we're going to go ahead and get into Q&A. Just a reminder, this session is being recorded, and it's really, we want to make sure that we capture all the critical data that we've been talking about today, so that's really the intent. All of this will be posted online, so you'll be able to share it with your colleagues and with your coworkers, so that they can learn more about what we're talking about today. So without further ado, we've got a wireless mic, so don't be shy, raise your hand. Monica's going to come around, and we'll ask to stand up, ask your question, and our panel will take it from there. So who's first?
Any takers? First question.
Oh, come on. There's got to be one out there.
Explained it perfectly.
Bill Gaylor. How does the federal standards and policies impact what you guys are doing around interoperability and so forth?
We can pass it down the line here. So, as I mentioned with the High-Tech Act, there's a lot there around federal standards. So those are all coming out of the federal level Office of the National Coordinator for Health IT and Center for Medicare and Medicaid Services. But I'll defer to Ben and Chris to talk about it more. The goal through all of these is alignment between the different architectures. So when we talked at our interoperability grant meeting last week, we're looking at how we align these. So MIDA is Medicaid specific, although within our department we have more than the Medicaid program. So we are looking at it from a general perspective, because if you look at the business processes, you could take the word Medicaid off, and these are general processes for healthcare delivery. So we are looking at it broader than our Medicaid program. However, because we are a Medicaid program and that's what the architecture CMS expects us to use, that is what we're using. That being said, CMS is working on has in developing this, made sure it's consistent with other types of architecture. And so that's where the different national models all start to play together. And, for example, in the health side, we have HL7, Health Level 7 is one of our major standards, but that will then work with NEAM, the National Information Exchange Model. So it's how these pieces interact.
Yeah. And on the technology side, CMS has the 7 standards, terms, and conditions, and part of that has to do with federal money that comes into the department and comes into the state. We have to satisfy all of that criteria. So with the advent of the Health Benefits Exchange and the California Eligibility Enrollment and Retention System, we're building that into that process. So as we integrate systems, we look for like functionality across those systems, and we have to abide by those standards. If we don't meet the standards, we don't get the funding. So it's become ever more important now that we have an architecture framework like we just showed you today in order to be successful and ensure that money continues to flow into the state. So that's really important as we align the technology piece with the lines of the business.
Thank you. Any other questions? There we go.
Hello, my name is Chris Hartman. I'm from Dell. I just wanted to say, first of all, I think you putting together your framework and all of that is a major victory for you folks. But I just wanted to say, you were talking about the elephant. From this gathering of data, do you have any idea where you're going to start in terms of this conversion to modernize?
Well, I can tell you, going back to that slide, that's my favorite slide in the whole slide deck, obviously, is looking at each one of our competency areas within IT and then working with Dr. Scott and the policy folks. And really, it's around data. We have many data tools. We talked about data analytics. We have program integrity and fraud units. We're using multiple tools to do the same thing, and it's costing the department millions of dollars. So that's really where our focus is getting to that priority, figuring out what that baseline is, and then taking it from there.
That's sort of what I thought, but I didn't want to listen.
Yeah, good question.
Great question. Anybody else? Oh, don't be shy. There we go. Third row.
Carl Engel from Allianz Strategies. So, great plan. What's it going to take to carry it forward? What are the major roadblocks you're going to have to move this whole process forward?
I think we've started that with the communication, and with the communication, it required the buy-in from our executive management. So we have director, chief deputy director buy-in, Dr. Linette Scott, Chris from the technology. So I think that's the start. We're really talking about a lot of changes. Moving more towards a services-based environment, and this is where I'll be talking to some of my sister departments that are already doing this. How did they get there? What were the barriers they had to face as well? And the vendor community is going to have to help us get there as well. But I think there's going to be, barriers that are seen and unseen as we go forward. So the more we can identify and head those off, but I think most of it's going to be communication. I think there's a lot of what I'm going to be doing is trying to get out into the business areas and learning their language, speaking their language, understanding what it is that they need, and then bringing that back and seeing where we can put that into a strategic plan.
Yeah, and I think, Carl, on an enterprise level, I think the sandbox issue is still a barrier. People want to have their own kingdoms, and it's hard to get out of that. Sometimes, you got to play nice in the sandbox, and that's the biggest issue, too, is we still have folks that want to own and take ownership and see that as an exclusive process, and those are some of the areas that we need to address.
We have a question back here.
Hi, this is Raj Anthony from Deloitte. First of all, thank you very much for this opportunity, and you guys have done a great job in explaining things to us about your vision. So this is a great opportunity for us to listen to you, your vision, and what the next steps. And as you move forward, would you be continue to have these kind of meetings and conferences where you involve the vendor community in terms of specific initiatives as you get into them?
I know from my perspective, yes. I mean, we look at this as sharing information. And again, this is a partnership. And the more information that we can provide you, the better we're going to ensure that the systems and the things that we do at the department are going to be successful. Because, prudent business planning leads to success.
And I think another parallel piece to that, if you haven't been following the leadership role from Cal OHI, which is the Office of Health Information Integrity, that's where our lead is for our health information exchange activities. So the Deputy Secretary for Health Information Exchange, Pam Lane, is also the director of Cal OHI. And they've been providing a tremendous amount of leadership in terms of looking at data use agreements, modular data sharing agreements, and working with the groups, especially like the Health Information Exchange organizations I mentioned, in terms of how to bridge between those. So there's also a tremendous amount of leadership and work coming from that area as well, and they do a lot in reaching out to the community. So keeping your eye there on upcoming events, webinars, et cetera, is another good place, I think, to get a sense of what's going on, in addition to what we're doing within the department.
Who's next? Anybody else? Going once? Twice? Bueller? All right. Well, I want to thank everybody on behalf of TechWire.net, Enterprise Networking Solutions, and MCorp, and our esteemed panel. I want to thank everybody. If we give them a round of applause again, I really appreciate that. And just a reminder, all of this is going to be online at techwire.net here in the next couple of days. If you have more questions, the presentation, the video, all the questions and the Q&A will all be online. And look forward to doing more events like this in the future. So thank you all very much.